First of all, I want to thank Dr. Marcus for inviting me. My name is Helio Vieira. I'm a trauma surgeon, and I'm also involved in an acute care surgery. I work as the head of the trauma department at my hospital. And I'm going to show you a little bit of it before we start. This is Brazil. We are staying right here. So the city that I'm talking about is Niteroi. This is Rio de Janeiro. Here is Copacabana Beach, Ipanema Beach. I live here by this lagoon. I cross a tunnel, then a bridge, then I reach Niteroi. That's where I'm staying right now. It's a 450 bed hospital that, for a Brazilian point of view, it's a very huge hospital. Not many hospital has more than 500 beds. So we are right about here at Unit 5, and this is the trauma building at my city of Niteroi. So I'm gonna present to you a case of a 24-year-old male that presented it in the ER 30 hours after falling from heights. The abdomen was pressed against a chair. He was pretty stable, and he was complaining about abdominal pain that reached 7 in a 1 to 10 scale. The trauma mechanism was something like that, or maybe like this one. And we need to use this scale, and I'm gonna tell you in a few seconds why we used to use this. He showed no signs of trauma in the ectoscopy, no signs of peritoneal irritation, and his mother reported hematuria that was confirmed after a urinary catheterization. It was an uncooperative patient and a very difficult patient for you to access. He had a chronic neuropathy and a cognitive impairment that limited the physical examination. He comes from a very low income family with many social problems. He was epileptic and had other admissions due to trauma. The last one, before that one, by a self-aggression in the face that requires surgery. So it's a very difficult patient for you to handle. The lab tests are quite normal, as you can see on this view. And we perform a CT scan that I'm going to show you. If you want to rewind it, just ask me, please. The name of the presentation gives you a clue, but there's some blood, then one kidney, then another kidney, then, oops, just one kidney. And another cut. Let me fast forward. And another one with the excretory phase. And the kidney seems to work just fine. This condition was unaware by the patient and the family. And the radiologists told us that we are dealing with a horseshoe kidney with grade 3 renal injury, with some free fluid in the cavity, compatible with blood, retroperitoneal hematoma, a cortical medullary laceration at the isthmus, and subcapsular hematoma. The kidney concentrated and excreted urine in physiological time. So there's nothing to worry about that. So we are talking about grade 3 kidney injury in the WST organ injury scale. And we can find the word horseshoe kidney in this algorithm. And at that point, I want to bring you guys to the discussion. Any comments so far?
Atlanta, Dr. Frisbee?
Oh, I don't have anything to say right now. I've yet to encounter one, thank God. I'm not sure exactly what I would do in this case. So I'm going to leave it open to other people to tell me how to proceed here.
Thank you, Dr. Frisbee. Dr. Ochman, Boston.
Sorry, I have one question. There was no urinary extravasation because I thought I saw urinary extravasation because that would make it the grade 4.
No, there was not.
No, okay. Well,
we're pretty sure it's a grade 3.
You're pretty sure it's a grade 3. Okay. The treatment for this is the patient is not hemodynamically unstable. It's just expectant treatment. There is no active extravasation. I wouldn't embolize anything. I would just wait. That's all I have to say.
Thank you, Dr. Ochman. Baghdad, Dr. Antrat.
Yeah, so just a couple of questions. Did it fall from a height? But so it sounds like he, because of his cognitive impairment, he fell over the chair, the back of the chair, and out a window. Is that what happened?
No, he was playing. He was playing, and the belly goes like this in the chair.
Chair, but you said fall from a height, just over the chair.
No,
in the house somewhere.
No, the same height. I'm sorry.
Same height. Okay.
It was a standing.
So okay, it wasn't right. Okay, and then so he's arrived 30 hours after the injury, so he's beyond. You know, if anything, he may have something that may present a late complication. So nothing really serious. And then looking at the first CAT scan, so it looks like the isthmus is inferiorly, horseshoe open superiorly. So there you go. But in the first scan, it almost looked like that there was a big retroperitoneal hematoma across the midline. It's basically zone 1 in the first scan that you showed, and it went by quickly. So I don't know if that, okay, so there's the kidney, and then behind the pancreas, before you get to the horseshoe is inferiorly to the pancreas. So where's the pancreas? It looked like zone 1. There's blood around the little bit around the liver, and if you find around there, right there, before you get to the isthmus.
Sorry,
it looks like there's hematoma and in zone 1, and even behind the pancreas. So that's concerning. That the hematoma there requires exploration. It's not just limited to the perinephric space. That's my only concern, that if that's what he has. So but the radiologist didn't mention a zone 1 hematoma posterior to the pancreas. Is that, if I understand correctly, it looked to me that was the case. Were that the case, then that would be a different situation. Otherwise, I agree with Dr. Oyman. A stable patient with a grade 3 laceration of the kidney, you can observe. If it's limited to that, but if you have signs of other injury in the abdomen, perforation of an intestine, or you have blood elsewhere, that complicates the matter, and that would if there's some change in the patient's status or worsening pain, that would miliate more toward exploration.
It seems to be a kidney only trauma, just to the truth.
Okay, if there's only kidney trauma, only kidney, then I agree with Dr. Oyman that, and the fact that it's a horseshoe but still has 2 ureters and 2 pedicles, and you would still, treat it like a, if it's unilateral, more to one side, just treat it as a grade 3 renal laceration.
Thank you, Dr. Antrach. Philadelphia, Dr. Nedelkovici.
This is a rare injury and a rare type of patient. I've never encountered anything like this. We may have had one at Ryder when I was a fellow, but there was some extrav and we went the route of IR and embolization. But I agree with Dr. Antrach. I would worry about everything that's in the retroperitoneum that could be injured. This is, in other words, a handlebar kind of type injury. So, it's a valid concern to, be worried about the pancreas. With regards to, that if there's no injury, then, fine, we'll leave it alone and just kind of follow this and treat as a grade 3 kidney, which has no extravasation of contrast, so no need for IR. There is no injury to the collecting system because we did not see any contrast leaking out. So I would watch it for now, and he'll need some repeat imaging to make sure he doesn't develop a pseudoaneurysm or any other problems. So maybe from that standpoint, just an IR angiogram to make sure there's no pseudoaneurysm that may cause a problem later. That may be actually something to do and consider. And I would consult a urologist and try to find out if anybody else had experiences with this type of problems to, get some more wisdom. Thank you.
Thank you, Doctor. Dr. Colette, would you like to comment or would you like to wait? I'm not sure if you had a chance to listen.
Yes, I went to late. I am later here. I went to late. Next, I can comment. I can see more on the case.
Perfect. Thank you. Dr. Vieira, please.
Before, if I can just ask another
Sure.
question. Oh, that last cut,
Sure.
the last image that you just had up there. No, that on the CT before you switch to this one. That last one, that's what looked to me like a retroperitoneal hematoma that showed the behind the horseshoe.
Here?
A little bit more. Whoa, right there.
There, right there.
Is that the renal capsule?
Yes.
Well, it's
Sorry.
Okay.
Yes, it's a
Okay.
subcapsular hematoma.
Yes.
Okay.
Can I move on?
Sure.
Sure.
Okay. I hope everyone can understand me because I'm going to struggle a little bit with the language now. So that was the description, the summary of the description by the radiologist. We go for this. And we pretty much have 3 options in our point of view: the non-operative management, or embolization, or open repair. And that's the real challenge, is what path we should take, because talking to the patient's mother, at first glance, an open surgery would give me an opportunity to prevent a new episode, because the boy just stands still. It's very struggling. He cut himself, he punched himself. So it's difficult for you to manage in the ward. And that would be my first questions. My first question to you all. In a patient that you have difficulty controlling in the ward, would you change the conduct regarding the surgery or the non-operative management? But we can talk about that later on, sorry. That's a list of cases that some authors put together discussing horseshoe kidneys embolization. As you can see, there are few lesions, trauma to the kidney that occurs in the isthmus. Just one from this publication here. Can you see my arrow? Okay. So
Yes,
there's a
yes.
kidney transection right here. And As you can see, the location of injury may vary from the left lower pole to none to lower branch of the right artery, and just one with the kidney transection like this one. And they did the embolization. The first thing that I remember when I saw that case was to think about a kidney like this. Okay, it's a hard to handle patient. Maybe if I cut right here, I can avoid further problems with this kidney. But as we go deeper in the case, and there's another reconstruction of the CT scan, I was a little bit naive about the situation, as you can see here.
Oh, yeah.
And as you can see here, sorry. And I want to highlight the vascular part of this. As you can see, there's an artery that arises from the left iliac artery. There's a left renal artery that sends a branch to the right side. There's two right arteries. 1, 2. There's one that comes from down here. So as I call my Yoda master trauma surgeon that teach me how to operate on people, he told me, have you ever operated on a kidney like this? And I said, no. So it's going to be like trying to eat a boiled egg with a spoon on a lunchbox. There's no right way for you. It's a dream. So at first glance, looked like this, but after I studied a little bit, it was like this on my mind. So that was the challenge. So I had to dig a little deeper and study all over again about horseshoe kidney. And I found out it's the most common congenital renal anomaly, occurring in 1 in every 400 people. The incidence is 2 to 1 in men. It has a normal function in most cases, but what really it's difficult about this, it's the abnormalities in its vasculature and sometimes serious changes in the urinary tract. Diffusion takes place at the level of the 3rd or 4th lumbar vertebra, so it's quite low. It might be composed of parenchyma or fibrous tissue, and the horseshoe shape surrounds the inferior mesenteric artery. I didn't know that at the time. I had to study. It's something that we don't see very often. 70% of the cases are varied. It's a varied combination of renal supply that can be composed of a single or multiple ileum associated with vessels directly penetrating the organ isthmus, as you can see in our patient. There's a lack of protection, so the kidney, it's more fragile to trauma. And blunt force injury to these anomalous kidneys is challenging with regard to non-operative management, especially if it's a high-grade injury with active bleeding. So do we go to the surgery or do we observe? And when I think about the surgery, I'm thinking about a very hard to handle patient that can injure this kidney all over again. So in the back of my mind, I was trying to protect the kid from another injury. And I would like to hear from you guys, what do you think about that?
Like that, Dr. Antrach?
Yeah, so, right. So I guess it's a unique case. None of us has, I take it no one else on the panel has had experience with operating on horseshoe kidney. I've seen on occasion, you know, patients come in solitary kidney or horseshoe kidney. You see it on the ultrasound, but you know, that not with the characteristics of this patient. But none of us has any experience, any literature. I haven't reviewed the literature. And so I guess what you're thinking of is to just separate the kidney, separate the Siamese twins, and let them fall in the retroperitoneum, and you know, you know, and I don't know how many cases like that are in the literature. It might be, if you did this, a case report. So you studied the anatomy like you did, and the collecting systems are normal, and there'd be perfusion. If you separate the isthmus, both kidneys would have adequate perfusion. I suppose that's okay. And certainly if there were another indication for a laparotomy, I would be, and were I prepared, knowing the distinct anatomy here, I would consider it. But simply for the reason that you said, and there's probably nothing in the literature about this particular situation, I think you'd be on solid ground. You should write it up if you did that. But if there's no other indication for a laparotomy, what I might say is this is the first time. If it happened a second time, and okay, then you know, you don't want a third strike. But you know, but either way, you know, if you do your homework and you're prepared and you know the situation, the home situation, whatever, you know, I think you'd be on reasonable ground. And then the other issue is, why did the mother bring the boy in after 30 hours? Why, you know, whatever, he fell. So something happened after leading up to 30 hours. There's an evolution that made her concerned to bring him in. That would be another concern in the back of my mind, that maybe there's something else going on that might require a laparotomy. So anyway.
Dr. Niteroi, is that Dr. Antrach? Is that a question for Dr. Niteroi?
Yes.
Okay.
Yeah,
well, but I mean,
the reason
in the discussion, he can answer this. Yes.
The reason it's the family. It's a very poor family, and the boy start to develop abdominal pain. For her, the hematuria was something that she would expect from him, from his behavior, and she didn't pay attention to that. Only when he had some abdominal pain, she decides to bring the kids.
Right. So, I mean, evolution of worsening abdominal pain with time, that I would be concerned about that there might be something else that would indicate a laparotomy in this case. And if so, I would consider what you were thinking to separate the isthmus.
Thank you, Dr. Antrach. Dr. Ochman, Boston.
This patient been 30 hours already, so I don't think he has any other injury except this one in the kidney. I doubt that he has a bowel injury or anything else. Again, I haven't seen the patient, so I might be wrong. So in these cases, I tend to go with the simplest approach, the KISS principle. Like in any emergency case, I've been called to solve a specific problem. I'm not going to make things perfect. That's for someone at a later time as an elective case to decide what to do with a particular thing. In an emergency case, I just deal with emergency and see what happens. As Dr. Untrach said, maybe a second strike, I would think different, but in the first one, I would not. If this patient has a chance of injuring himself, that also I have to take into consideration. If I give him a laparotomy, I put him at other risk. So I would just, if the guy is doing okay, I wouldn't do anything else. I would just continue to observe. He might be a difficult patient. Maybe he would need to be, I don't know what the facilities are where you are practicing, but here in difficult patients like this, we would probably intubate the patient and wait a few days in the ICU and wait the things that way. But again, without seeing the patient, it's difficult to say. So I wouldn't do anything else at this time. That's my short answer. If he needs something, I would wait to do this electively by the urologist who might do this more frequently. If it's an emergency, I'll do it myself, but at this time I wouldn't. Thank you.
Thank you, Doctor. Dr. Frisbee, Atlanta.
Yeah, you know, I tend to agree. If you go back to that CT picture that we had of the subcapsular hematoma there, I think I probably would observe that, see if it's expanding. If it's expanding, you may have a real indication to go in there and do something. But if it's not, and he's not really pouring hematuria, I might tend to wait on this and see what develops. You've got a whole lot of negative issues before you even do anything with this patient. So I might want to just see if that hematoma is going to stabilize, or if it's going to expand. If it expands, then you have a couple of options you could use. You know, if you have the ability, you could turn him over to see if you could get a embolization in there, but or you'll eventually may have to operate on him. But I think at this point, I'd wait to see if that hematoma expands anymore. That's all I have.
Thank you, Doctor. Dr. Nedelkovich, Philadelphia.
So just because he's a difficult patient with his underlying problem, I don't think that would make me do something different in terms of taking to the operating room. I would certainly, again, see if there's a urologist who have some sort of an opinion or experience operating on this, just to kind of plan ahead so he's not hitting the door of the hospital and, you know, he's not known, or the case is not known to everybody. With regards to the grade 3 and the AAST, you know, classification and all that, you know, this is an abnormal kidney. I wouldn't do anything different than maybe just an IR angiogram and make sure there's no pseudoaneurysm that may cause a problem down the road, if that's possible, and doesn't add any risk. Because to work this up and look with an ultrasound, see if there's any pseudoaneurysm, you know, that's hard because you're going to have all this bowel on top of, you know, you're not going to get a good view with that. So I would say I would, you know, maybe err on the cautious side and just do an IR angiogram. Thank you.
Thank you, Doctor. Dr. Collet, would you like to comment?
Yes, first, I think it's very important because usually kidney injuries is associated with a kidney defect, a disease of the kidney. Some kidneys, normal kidneys, rarely have injury on the blunt trauma. You have a horse kidney. It's very difficult to decide what to do. You have a problem here. You have a hematoma. You have this hematoma. I don't know if there is some collector injury, okay, or if you have injuries of the system collector. Sometimes when you have a problem with this kidney, you have a problem with the collector ureter and pelvis, and can be injury. And it's very important to see the late phase to see if there is injuries of this collector system. Sometimes the collector system may be associated, because you can see here has the dilatation. Sometimes you have stones in this ureter, and sometimes you have a problem. It may be difficult to treat sometimes the patients because the stones and the clots may be can be obstruct the ureter, and problems then can arise in this situation. And so I believe this patient is stable. The hematoma is stable. There is no blush. You can wait and observe. Sometimes if you have a late phase, you can see, repeat the urinary phase to see the ureters, and then you can show if you have collector injuries, can put WG stents in the ureter, can be very useful. And when you have injuries on the collector system in blunt trauma, sometimes I can see some blunt trauma in penetrative trauma, then put in the collector system. If the patients become unstable, you can see a blush. cancer. In this situation, if I have no other injuries in the patient, I go to patient to angial embolization and try to find the correct place and embolization the place. Try to avoid to put my hands in this kidney, because I know that the problem is very difficult, but sometimes there is a process around the vessels. It can be very difficult dissection in this situation and can be more damage in the patient. So in this situation, I put the patients, if the patient is stable, I can observe. If the patients have hematuria, can be considered as a collector injury, I can count the urologist to see, and sometimes to put a stent, double G stents in the ureter. And if there is a problem, there's a blush, I go to put the patients, if possible, to endovascular treatment and try to embolization the kidney. The patient, I have very, very problem with the patient is extreme anxiety. The patient is round, and I don't agree sometimes to put into patients this patient. I try to make some people call the psychiatric and take some drugs. Maybe the patients avoid to make intubation and put this patient in ventilation, assist a ventilation, because the risk of pneumonia associated with ventilation is very high in this situation. So I try to avoid this. So I try to call some psychiatric, can maybe some help and make some drugs, maybe put the patients more calm, and maybe so I can go and wait and observe the patients. I think the first is conservatory management. And if the patient have some injuries, can go to a stent in the WG in the ureter, collector system, and sometimes embolization. I have one case, this one, and these patients have a very big stone in the collector system. The problem is the rupture of the collector systems in a patient like this with a horse kidney. So it's very, very, very rare case, but it's very difficult decision to have to have. Thank you.
Thank you, Dr. Collet. Dr. Vieira, we go back to you.
All right. So we decide to go with the as part of our homework, we found out the trauma and pre-existing kidney disease. 57% of the indication for surgery depends on the hemodynamics and the underlying parenchymal pathology, such as tumor. For an injured diseased horseshoe kidney, surgical reconstruction and preservation of the damaged kidney is difficult because of variation in its vascular anatomy, as you all said before, which could lead to failed preservation of the kidney parenchyma. We decide to go with the non-operative treatment because of the hemodynamic stability. We talked with the endovascular crew, and we found out that the failure in this kind of treatment is higher than in normal kidneys. And because of the comorbidities that the patient has, like recurrent respiratory infections, chronic neuropathy, and dementia. So we choose to go with the non-operative management. On the fourth day, it has an pain maintenance, less hematuria, but still present. The hematocrit drops to 28, hemoglobin to 7, with the locometry quite normal. Do we still go with non-operative treatment, or can we call the endovascular guys? Do we change our management?
Dr.
What are your thoughts on that?
Yes.
So the hemoglobin dropped from what, from 12 to 7?
Yes.
Basically.
In 4 days.
So I would like to make sure that the hemoglobin is real, put together with the hemodynamics and the kidney function, the creatinine level. Then you have to decide if it's hemodynamically stable, it's just a drop in hemoglobin. Is this equilibrating, or is he actively bleeding? If you decide that he's slowly bleeding, then on your assessment, and have to see, take into account the creatinine before you scan him and send him to IR, or just send him to IR for an angiogram. But I'll try to stay away from operating on this. So probably IR if creat is okay, or maybe up a little bit to minimize the amount of IV contrast that I will be given, or rescan first and then go to IR. Sometimes here we cannot go straight to IR unless we image and there is a blush or something like that.
Thank you, Doctor. Dr. Rahman, Boston.
Well, maybe I'm too lazy, but I will still do nothing. You expect these patients to bleed, so this is within what you expect in a patient like this. Yes, you can do a CT. Most likely the bleeding is venous because the patient is very stable. Could he have a pseudoaneurysm? Yes, he could, but I will still wait for now. And I will not operate. The moment you operate on this, in all these years I've been doing trauma surgery, only once I was able to save a kidney after trauma, because usually when you operate, it's such a mess that you end up doing a nephrectomy. And this guy, if you do a nephrectomy, you're getting forced to do a nephrectomy, this guy would need dialysis. So I would be very reluctant to operate. The moment that you decide to open this guy, you own the kidney. And unless you are 100% sure that you can do what you were planning to do, which I think that is almost impossible in an emergency situation, I will do everything possible not to operate. And I don't think he's bleeding enough to see anything in the angiogram. But it all depends on the clinical picture. Maybe I get a CTA, but otherwise I would probably wait. Thank you.
Thank you, Doctor. Dr. Antrich, Baghdad.
Yeah, so I think that's prudent. Also, so this is the second hematocrit since the boy was admitted. It was 36 on admission, now 28. 28 is more consistent with all the blood that's on the CT scan, so that might just reflect rehydration. He came in, the 36 was before he got any intravenous fluids, and it might just be all the fluids he got, that he's not still bleeding. There's less hematuria, but I think it's reasonable, as Dr. Alex mentioned, to rescan him, check the size of the hematoma. If you have an expanding hematoma, it keeps expanding and significantly and it won't stop, that's an indication for surgery. But I think it's prudent, to not to operate unless you absolutely are forced to. And then if you're forced to, in the process, whatever you have to do, you might wind up dividing the isthmus. And Dr. Oyman before said he didn't think there was another injury other than the kidney. And I guess that's probably right, because the mechanism of injury was trivial. But for the horseshoe kidney, he wouldn't have bled into the belly, and it's on, just the kidney was vulnerable to injury by a trivial means. So yeah, I think that makes sense. That he's very unlikely to have anything else injured, but he may just be suffering from the hematoma that expanded initially, caused more pain. He came in. The other point about the IR, if I read the slide correctly, that interventional radiology often fails with horseshoe kidneys if you need to use it for intervention. I guess you can use it for diagnosis.
Yeah, you're right.
It fails for intervention, but not for diagnosis. If you want to see if he's bleeding from someplace, which side, what vessel leads to the right. But then once you find it, intervention often doesn't work, and embolization often doesn't work. So then, but I guess in any event, you would wind up going to angiography first to see where the problem is, try to fix it that way. If he were bleeding, if it didn't stop, you'd have no choice. And, and at that time, especially if the bleeding is around the isthmus, it'd be reasonable to just divide the isthmus, which would be very anterior in the abdomen. It'd be over the lumbar the spine, almost right, move the bowel away. It should be right there, obvious, in front of the aorta. So, yeah, it's a conundrum, but first do no harm. And I agree. You want to really be sure you're forced to, and that only if the hematocrit keeps falling below, 20 and you have to start transfusing, then I'd be more alarmed.
Thank you, Doctor. Dr. Colette?
Yes, I think this patient needs to see what's happened. So I think in this case, I go to make a new angio CT to see if the hematoma is expanded and there is a blush or not. So, and then if there is not, I continue conservative management. If there is a blush or increase the hematoma, I go to make angio and eventually to go embolization.
Thank you, Doctor.
That's exactly what we did. We repeat the CT, nothing new. So we decided to keep on going with the non-operative management. We did some blood transfusion, pain management. We talked with the endovascular team, and they thought it was better not to address the problem. We discussed the case with the urology. They thought it was better not to address the problem, and we strongly agree. We did a control CT 24 hours after the admission on the day 4, with 1 week and 3 weeks later. The patient has had a favorable evolution with progressive reduction of symptoms and hemodynamic stability. And he was discharged from hospital for outpatient follow-up 9 days after the admission. And here's the CT scan 3 weeks later. All right, that's it for your final thoughts, I guess.
Thank you, Dr. Vieira. Dr. Colette?
Yes, I have to congratulate the case. It's a very interesting case. Sometimes it's very difficult to manage these patients. These special patients is very, very difficult to manage. Congratulations. Thank you for sharing your experience with us.
Thank you, Dr. Colette. Dr. Hochman?
Yeah, no, a very interesting case. We had one horseshoe kidney with an injury in the same location, but it wasn't so severe, like 2 weeks ago. It was also grade 3. This looked worse than ours. So the few things, why I wouldn't do the CT scan, again, I don't think that the degree of bleeding indicates an ongoing arterial bleed. If it's anything, it's a venous bleed. And in this patient, I will do everything possible not to operate. I think that dividing the isthmus sounds easy, but it's not. And the chances of causing an injury that will cause the patient to lose the kidney is very, very high. So I would operate on this patient at the very, very last resort. When the patient is actively bleeding and I cannot control it any other way, okay, fine, we need to take the chances, and life takes priority over function. But otherwise, I would do everything possible not to touch this patient. One interesting finding on this CT scan, he has a very large colon. And I know
Yes.
he's in Brazil, and I know that Chagas exists, but probably he's too young to have acquired Chagas. But I have seen quite a few patients during the years who have neurological disorders like this patient you're describing, that they develop for some reason, I cannot explain, a megacolon, a non-Chagasic megacolon, and they ended up having to have a total colectomy. So I wouldn't be surprised if this guy has to come back in the future to have a total colectomy for a non-functional colon. That's kind of a little tidbit there, but it's really very well managed, and you cannot argue with success. Congratulations. Thank you.
We are not in an endemic area for Chagas disease. Maybe it's because the underlying condition of the patient, the colon.
Thank you. Dr. Frisbee, Atlanta?
Well, I was always taught if you ever see one of these things, run from it, because if you try to operate on it, you're not going to do well, and neither is the patient. But I think the management was appropriate. You know, he didn't look like he was really pouring out, and it took him days to drop down in that hemoglobin. At this point, I think it was very well managed, very nicely done.
Thank you, Dr. Frisbee. Thank you, Doctor. Dr. Antracht, Baghdad.
Yeah, yes, great case, a different kind of a case. It's a rare pathology that we almost never see, but it really gave rise to a very good discussion about surgery in general. First, do no harm, you know, and then you said, you know, were you to operate on that kidney, and that tomogram that you have on the screen, it looks like the isthmus really belongs to the left kidney. And, you know, I don't know if so you'd have to know that ahead of time. And if you just divided the isthmus over the aorta, you'd wind up transecting or dividing the getting into the collecting system. So it would just really one of those situations where, you know, once you got into it and got started, you'd feel very sorry you were there. You know, and we've all experienced that from time to time, but it was really a very good case for discussion, raised a lot of interesting points, and is well handled.
Thank you, Dr. Antracht. Dr. Nedelkoviciu, Philadelphia.
Thanks for presenting it. It was definitely a very helpful and good learning opportunity, I think, for everybody. I would definitely get a recon images on something like this if I ever encounter it. And everything is rare until it happens to you. And congratulations for managing this the way you did, and for sharing it with us. Thanks again.
Thank you, Doctor. Dr. Vieira, there is a question in the chat that says, how long did you put him on bed rest for non-operative management? I'm not sure if you answered that question already.
I'm sorry, come again?
Yes, there is a question on the chat that says, how long did you put the patient on bed rest for the non-operative management?
He simply didn't lay down on the bed at any time. So it's impossible. We just closed the door of the room and keep asking him to lay down, but he was a very, very hard to handle patient. And with his mother begging him to lay down, but that's another part of the challenge. And
okay. Thank you very much, Doctor.
I would like to thank you all for the comments. The reason that I bring up this cases to share our view from quite a unique case, and there's a lots of opportunities for us to learn something about this case. So thank you for the comments.